Hello, I'm Nathaniel Neptune. I'm a current MD MBA student at Duke University, and I'm here to discuss reference-based pricing in the landscape of value-based payments. The agenda for today includes defining what reference-based pricing is and what it is not. Then I will discuss a few pros and cons of reference-based pricing, along with a couple of case studies to illustrate those pros and cons. Then I will conclude with a couple of takeaways of today's discussion. First, for reference-based pricing, I do want to let you know that every time I define or discuss reference-based pricing, that will be limited to how it is used in the United States and not at the international level. The international level is beyond the scope of this discussion today. I consider reference-based pricing to be a form of cost sharing, and we'll get into those details in a little bit. One change that is different with reference based pricing from how most payers provide reimbursements is that the consumer is actually reimbursed directly for all healthcare services, and the consumer is then responsible for passing that reimbursement on to the provider. So instead of the payer directly reimbursing the provider, the payer actually reimburses the consumer, who then has to pass on that reimbursement to the provider. And the payer sets a contribution limit towards payment for any product or service that is rendered by a healthcare provider. And this contribution limit is typically set as a median of the prices charged by a health service provider. So, for example, let's say you wanted laser eye surgery here in North Carolina and a payer wanted to do reference based pricing. What they would likely do is determine what all of the laser eye surgery centers in North Carolina are charging. And once they determine the median price, they would set that as the contribution limit. So, therefore, you would be in charge of selecting a provider that charges below or at that contribution limit to ensure you don't have to pay additional fees out of pocket. Because consumers who select a provider charging above that contribution limit must pay the entire difference. And some payers, when they use reference based pricing, actually penalize any consumer that selects a provider that charges above the contribution limit by reducing the amount that they will give that consumer. So the amount that the consumer has to pay will increase even more because they selected a provider that charged above that set contribution limit. And the reason for this is to de-incentivize people from selecting providers who charge above that contribution limit. And one of the things with reference based pricing is that it increases consumer responsibility because the consumer is reimbursed directly and they have to pay the difference. So, in theory, this allows consumers to see how they are actually being charged by these providers and can possibly encourage consumers to pressure providers to be more transparent and clear with their pricing practices. And the additional thing that this does is it makes the consumer the middle person because the employer takes the dollar bill and instead of sending money directly to the provider, they send it to the consumer instead. And now this consumer has to pay the health service provider. And hopefully the consumer sees the difference in cost between different health service providers and they will choose the least expensive one, because if they choose a more expensive health service provider, then they're going to be liable for all costs that are above the contribution limit set by the payer. The entire intent of reference based pricing, particularly in the landscape of value based payments, is to encourage consumers to select less costly options, because the equation for value is quality over cost. So if quality remains the same and you reduce costs, then you should increase value. And we'll discuss this more later on in this discussion. So let's say we go back to our previous consumer and they need a colonoscopy. They also need a new prescription drug. And in addition to that, they need blood work. Where should they go to receive all of these services? They have Hospital A and Hospital B right next door to them, and both of them provide similar services at an equivalent level of quality. Hospital A, however, only charges $1 bill, whereas Hospital B charges $3. The intent of reference-based pricing is to encourage the consumer to select Hospital A because the contribution limit will be set to only $1 bill. So if the consumer selects Hospital B, then they will have to pay the additional dollar bills that are over the contribution limit. This is why I see reference-based pricing just as another form of coinsurance, because coinsurance typically pays up to a certain amount and reference-based pricing is very similar. Now, one thing that reference-based pricing is not, it is not a denial of services or rate capping. Certain people mix up reference pricing with rate capping. These are two completely distinct things because reference-based pricing does not enable payers to limit how much providers or pharmaceutical companies or other health service entities charge for services or for products, and it also does not deny patients from receiving these services. One example of what is not reference based pricing is Montana State Health Plan. The state health plan did use reference pricing to set a limit on what hospital reimbursement rates could be, and that was an average of 234% of Medicare rates. And since they limited what hospitals were going to be able to charge, and they banned balance billing, which would not impact consumer behavior, many experts did not believe this to be considered reference based pricing. Instead, they consider this to be rate capping because it's not changing consumer behavior since it's not passing on any of the additional charges to the consumer. One pro of reference-based pricing was seen in California with the California Public Employees Retirement System. Prior to implementing reference-based pricing, there was a very high variation in how much reimbursement was provided for certain procedures. For example, knee arthroscopies, there was a 12-fold variation in how much reimbursement was provided. And all of the reimbursement varied simply based on who the provider was. After implementing reference-based pricing, CalPERS witnessed a $13.4 million savings in 2 years, and much of that was because they targeted select procedures that included colonoscopies, cataract surgery, arthroscopies, and joint replacement surgeries. The reason why this was successful is because all of these surgeries and procedures are simple, non emergent, standardized, and common. All of those factors make these procedures and surgeries shoppable. So patients were able to easily find access to providers that charge below the contribution limit that CalPERS set. And this is what allowed them to witness savings and increase buy-in from hospitals, because even with the lower reimbursement rates, 26 hospitals changed their prices to being below the contribution limit set by CalPERS. And this is because they wanted to attract those covered by CalPERS. Some downsides to reference-based pricing still exist, and one of them is that there's no emphasis on value. The same incentives as fee for service exist with reference-based pricing. You're incentivized to increase volume in order to increase revenue generation instead of improving quality to increase revenue generation. Reference-based pricing also encourages cherry picking because it reimburses the same for every single patient. Even if a patient has increased risk factors, which is known to result in poor outcomes, they will receive the same reimbursement as a patient with no risk factors at all. Narrow networks are formed by the use of reference-based pricing, especially if local providers are unwilling to charge prices below the contribution limit that is determined by the payer. And this can result in patients having difficult time finding care and receiving the services that they need. Also, balance billing tends to increase with reference-based pricing. In 2018 alone, there were 8 federal lawsuits against healthcare providers for the act of balance billing, where healthcare providers sue consumers for the remaining balance left after reimbursement. And also, consumers may not use the lump sum of money that they receive from the payer in order to pay the provider. And that could be due to a lack of knowledge about what that lump sum of money that they received from their payers for, or sometimes it's because the consumers have more urgent bills that need to be paid, such as housing expenses or food expenses that they use the funds received from the insurance company for. And this is where reference-based pricing with reimbursing the consumer directly instead of the provider directly has its downsides because of the increase of balance billing that is occurring. Some takeaways from today include that reference-based pricing can be applied to any health service or product. Reference-based pricing can be effective for certain select health services and procedures or surgeries that are standardized and relatively shoppable. Also, reference based pricing does not equal rate capping necessarily. Those are two different things. And the reduced reimbursements from reference based pricing doesn't necessarily improve value or outcomes. And the cost is oftentimes only shifted to consumers. So overall, societal costs are not reduced. Thank you for taking time to listen to me today. I would now like to acknowledge some people that provided indirect support to me for this assignment. That includes Andrew, Kevin, and Tess. We worked on a project last year related to reference-based pricing, and I used the sources from that project to assist me with this. I would also like to thank Mark McClellan and the Margolis Center for Health Policy for a course I was in that also provided some sources and perspective around reference-based pricing to help assist me with this project indirectly. Thank you, and I hope you have a good day. Bye.